At any rate, we had a really busy year. We had 1,880 overdose reversal attempts. We distributed more than 10,000 kits of naloxone. And I think what I counted was 8,000 encounters at the syringe site. So,
Yeah.
the Bree Collective is started by Dr. Bree. Oh, here it is. It's through the Foundation for Healthcare Quality. They have been working with the Healthcare Authority, HCA, to reform all kinds of different medical practices over the years since they were founded. I can't tell you off the top of my head when they were founded. We'd have to go look. This opioid treatment prescribing reform is the first time that the Bree has returned to a topic that they already addressed. So back in 2017, they came up with their first set of reforms around opioid treatment. And then COVID hit, and like the opioid, topography really changed. So people weren't, using heroin as much anymore. They were now using fentanyl. Heroin kind of dried up because the smuggling dried up, because the global commerce dried up. And how do we smuggle things but through legitimate commerce? They thought we need to take another look at treatment. If the substance causing opioid addiction has changed, maybe the treatment needs to change. So I was on that treatment reform review committee. I, was proud to be part of that effort, and I tried to bring like the community-based organization and rural area, perspectives to those conversations. I'm definitely a proponent, I would say, of low barrier access into care. When you look at all of the people addicted to opioids in the U.S., only about 10% of them in any given year access treatment programs at all. So I feel like we could do a lot better. We need to do a lot better. If we have this many people getting addicted to opioids every year, and we're treating this many people who are in that increasing pool of people, we never get to the end of this crisis. So, we need more than 578 treatment clinics in the United States.
Yeah, as you said that there's only that 10% here. Do you think what barriers would there be for people to come to Blue Mountain Heart to Heart and get treatment? Are there lesser barriers than nationally? Is there a comparison to that?
Well, there's a great variety of programs out there to help treat people whose drug use with opioids has gotten out of their control. And to be clear, like typically people do need help in order to address that behavior. They can't just move themselves out of being addicted to opioids. We don't require that you stay with us, so it's not inpatient, it's not residential, it's outpatient. You can, keep your life basically intact where you are and just show up. We have telehealth, so while we don't replace 100% of inpatient or in-person visits, certainly we'll have, a lot of flexibility for being able to see people just through, the screen, which makes it easier for them, to get the care that they need. We have wraparound care, so if they decide they really need help with some emotional issue related to their drug use, we have a free counselor for them to see and make that available to them. We don't require that they see a substance use disorder professional first and get an assessment, so it's low barrier in that sense. These are policies that many programs can avail themselves of, which I would also think that it would improve any program's ability to serve people if they, you know, were willing to navigate them onto insurance if they didn't already have it when they walked in the door. The traditional programs would say, well, we can help you with your opioid issue, but we can't help you with the meth that you're using. And because you're using meth, we won't see you, or we won't retain you in our program. We don't say that. We say, let's tackle these things one at a time if that's where you're at. We do also have a contingency management program, which is designed to help people who are addicted to psychostimulant products, help them stop using. That's an abstinence-based program. That there's no medication on the market that's been approved by the FDA for people to work their way out of things like meth and stimulants. So this was a protocol developed at WSU with small but increasing monetary rewards in the form of gift cards to help people stay off of meth. It's an 8-week protocol, and we've helped several dozen people at this point stop using meth. So that's good, but they can take that opportunity or not. They could still be just on the opioid side, even if they're not ready to address the stimulant side. So not every program does that. Every program could, so I advocate for flexibility in these interventions to help retain the people that they have who are interested. And when COVID hit and it disrupted the underground drug market, people began taking anything that they could find. Part of the problem for people who are engaged in using these substances is there's a lot of things that are out there on the market that do contain more than one psychoactive substance. So it remains true for what we've seen in our drug checking program. If you buy something sold as meth, it tends to just be meth, and that's it. But if you buy fentanyl or something sold as fentanyl, you may be getting xylazine, you may be getting industrial glue, you may be getting carfentanil, and you may be getting meth. And so people not intending to use meth may find themselves getting addicted to meth as well as the fentanyl that they're taking. We also see that there are these incentives for people who are unhoused to take meth so they can stay up all night, protect their belongings and themselves. And it's hard to argue, no, you really shouldn't take that when the last time they fell asleep, really bad things happened to them and their small cache of belongings. So, sometimes we just need to help people address these issues sequentially and not concurrently, and that's okay. But so I think polysubstance use is really common. It's not always intentional at first, and then it winds up being something that they kind of are stuck with more than one thing that they're tied to. I think we saw from the syringe service program survey that UW does every other year in the odd years, so the next one will be coming up this year, that a great many of the people utilizing syringe service programs do report some mental health issue or challenge. Obviously we see a lot of depression, we see a lot of anxiety, a lot of attachment disorder, but there are people out there with serious, not that those aren't serious, with other serious diagnoses, diagnoses related to psychosis, for example, to schizoaffective disorder, to personality disorders, where it's really hard for them without any help to kind of address the problems in front of them that they want to solve. So having a case manager or care navigator or a physician and nursing team to help people get through all of the all the paperwork, all the appointments, all the phone calls and logistics, all the medication regimens, that becomes pretty critical for them to have success. So I think we've been looking to hire an ARNP with a mental health prescribing background. We came really close with someone. Now we're kind of knocking on a couple other people's doors. I would like to increase our capacity around that. But we definitely help people with, either link them to care or deliver our own care to help them if they also have a mental health diagnosis that they want support with. I do think that there are people out there who are drawn to this kind of work, and so it becomes, recruitment becomes about making sure they know we're here and that we have an opportunity. So, we post things pretty widely, and every so often I run a really big ad in the UB, but I think there was a time when we were paying a bit less than some other providers in town, like large hospital organizations, etc. But we seem to have narrowed that gap. So things that I think that are appealing about the work are it's a small team, close-knit team. There are no real overtime hours, so we're not overworking people 50, 60 hours a week. And if you want to feel like you're making a difference, this is exactly the kind of job, where you can do that. Do you want to have to work with people with addiction and mental health issues? You do, it's not like being a nurse in an ICU where most of your patients are asleep a lot of the time. But we also tend not to have like huge emergencies all the time because we don't have people at a critical need of physical care. So it's like a different kind of nursing. It's a different kind of prescribing. But it really is a humongous help to a lot of folks and makes a real difference. I mean, somebody said to us last year sometime, like, you cared about me before I cared about me. Like, that's where we are filling in, is at that point of people have like a real collapse of confidence in them. So I don't think that that's as big an issue as it was in terms of like, do I want to work at that agency or do I want to work in that city? But I do think there is a larger strain on the healthcare workforce. There's so many of them are burnt out. Again, I turn to my, example of COVID. And I think that we've seen a real hollowing out across a lot of Eastern Washington with regard to specialist availability, general practitioner availability, and nursing availability in general. So it is a lot harder for me to hire a clinical person than it is a case manager, but I think we're doing okay. I mean, there have been a lot of programs that we have picked up over the years because nobody else was willing to do them. That's fine, but once we got to doing them and then proving the concept, I was like, well, now I gotta sustain it because I know this thing works. I know it helps. When COVID hit and everyone shifted to fentanyl, nobody was coming into the syringe exchanges anymore because they didn't want needles. They wanted something we didn't even have. But I said, okay, fine, let's try it and see if they come back. Well, everybody at the SSP gets a unique identifying number. That's how we know how many people are unique versus how many encounters that are just the transaction aggregate number. I saw new people come that I'd never seen before, and I saw a whole big bunch of people return who had stopped coming. And we went from like 40 transactions a month to 500. And I know when you come into it, it's very clear in the evidence base, if you come to a syringe exchange to get materials and have the interaction with us, you're 5 times as likely to get into a recovery program. So every best practice that we have for our syringe exchange is geared to getting you to return, right? And the lead program to divert you know, low-level offenses from people to get them to get into case management. It's all geared to getting them to return. If they're engaged and they have a case manager and they're working with us and they're trying to, you know, stabilize their lives, they're less likely to offend, they're more likely to reduce or eliminate their use of these substances, they're more likely to get their kids back, return to work, get housed, you know. Why not? It's good work, so why not do it? Yeah, so that's why I do it, because we can. The mountain is there, I know we can climb it. So.
What needs are specific to this community or are more prominent in this community?
I think Walla Walla has put together over the last 50 to 70 years. It's a patchwork, but it's a pretty comprehensive patchwork at this point between public agencies, nonprofits, and for-profit healthcare. We don't have a maestro. We don't have anybody aligning us and our efforts, and I find that to be a great shame, and I keep asking that somebody in power come up with that. And I know that there are efforts to make that happen, although it being Walla Walla, you're going to have people saying, we just want to do our thing over here. We don't want to be part of your maestro orchestra. That's fine too. But I think we've come so close, but we're missing a few key pieces, and if we could have those in place, I think we would see change like we have never seen it before, and everybody would show up here on our doorstep asking how we did it so they could take it back to their, I mean, I honestly believe that. Mm-hmm. Those things are, we need a permanent supportive housing program that incorporates a housing first value base or intervention model. That could also be incorporated into an accessibility housing program, right? Accessible housing program and an affordable housing program. I think that we shouldn't take everybody with a substance use and plunk them into the same 16-unit apartment complex. I don't, because then everybody's going to know that that's where it is, and there's going to be all the stigma around it. But if we had 200 units of affordable housing go in, and 50 of them were for earmarked to a permanent supportive housing program, I think it would work really well. That would be one thing. I think we need our own detox and residential or inpatient treatment program here in Walla Walla. Mm-hmm. It's really hard to ship people down the road to Yakima 2 hours or up to Spokane 3 hours. Just getting them there is very onerous and hard on the people and a big barrier to them entering into care. Mm-hmm. If we need to detox somebody, it's really difficult. They're either like hanging out in the emergency department, which is not designed for that, or they're sweating it out in the jail down there, which is not what they're designed for, or someone literally has to take this like shaking and upset person in their car with them mm-hmm. until they can get to a facility hours away. That's lunacy. Mm-hmm. So I think we really need that kind of program here. Mm-hmm. I think if we could get more people in mental health here to address what were the emotional and mental causes of someone getting into substance use. Some of these things are predecessors to substance use, and some of them are subsequent to substance use, and those might need different kinds of therapeutic responses from a counselor. We just don't have enough of those providers here for all the people who have those needs and need them addressed. Mm-hmm. So I'd love to see those things here, and I feel like the folks that we see in Benton County are so much more despondent than the people that we see here in Walla Walla. Like, we're so close to having some really critical pieces in place, mm-hmm. and good Lord, if we could just do that, I think there'd be a lot more people we could bring along. Other barriers that I see, like we just need more housing, period. And we need more support for women who have a typical presentation of domestic violence in their life. So maybe it's just a really abusive, emotionally abusive partner who has isolated them from their friends and their loved ones, but they're not really laying a hand on them, so they're not qualifying for certain kinds of programs. Some programs require that there be a DV report with the police department before they'll accept you and give you shelter. We just need more support around domestic violence and abuse more generally, so that we can have more resources to help people, because the biggest thing I see that pushes women out of care are those partners that are like not ready for her to reach sobriety.
Or do you see Blue Mountain Heart to Heart working with the city or other organizations here to try and solve those issues?
Yeah, I think there are really great efforts already, kind of en route to their destinations. I know that the commissioners for the county are, looking to find good projects to put our opioid settlement money into, to try to get some preventive results out there in the community. I think the housing question has kind of gone to that housing, that board of advocates, that group of advocates, who were the ones working with the commissioners to try to push them on the HB, 1070 bill. Remember they voted it down in November, and we really advocated strongly that they pass that 0.1% tax. They declined to do that and said, let's put it to a vote of the people. I don't see anything going to a ballot before May of this year, probably next November in all likelihood, which really just delays when money can be spent, because you have to approve it, then you have to accrue it, and then you have to decide what to do with it. So I think that group of housing advocates is trying to, comport with what the commissioners asked them to do, and also look at other alternatives for, launching a housing program here that would be centered around affordability, accessibility, and support. So we need to work with everybody. We need to work with the city councils, we need to work with the commissioners, we need to work with our LD legislators, and we need to work with our federal delegation to Congress, and we have. I think Heart to Heart does well at getting dollars in for specific contracts to do, the universe of work that we've done. I'm going to launch this year the Center for Rural Responses to Substance Use, our academic center, and working with our 16th LD delegation to put in a capital budget request just to get a researcher to start working with all of the reams of data that we have here, and try to figure out when something works, why is it working well, But I think, so I don't go into any contract, Julia, where I feel like it's really not going to work out financially. Every contract is buttoned up, makes sense, and has potential out years of support, so not just like a 6-month thing. When I hire someone on a permanent basis, it's with the idea that I will be able to continue to find money for their position. I don't hire people on a contract basis and say, your job is over when this 3-year thing is over. So if I have a program manager in our drug user health program, and we did like a project for the CDC from 2021 to 2023 to get people who use drugs vaccinated for COVID. And these were like the most hesitant people And the vaccine had been on the market for like a year and a half. So these were people who had avoided vaccination for 18 months and were really not inclined. So we when that program was over, I didn't say, okay, you're done. Have a great day. Take your learning somewhere else. I said, hey, we have a new program or project coming up within this program. So I'm going to need you all to adjust and, start thinking about this new thing we can be doing. And that's how I keep things going. So I feel like from the contract point of view, things are going really well. But for doing things around the edges or growing capacity or infrastructure, that is more of a challenge. I think that we are not unique in that regard. That's something all nonprofits face. And while I think it's concerning that the state and the county budgets are both facing deficit situations coming up, I'm not too concerned about the state cutting billions of dollars from behavioral health. I don't think anybody thinks this is the right time to back off of what we're doing around opioids. Every person that we can prevent getting hepatitis C saves our healthcare infrastructure thousands and thousands of dollars. And everybody in the ledge knows that. Everybody in Congress knows that. So unless somebody wants to really make it their mission to end funding around this, and I don't see that getting mobilized anywhere, I'm not worried about the funding for the kind of work that we do.
Yeah.
That doesn't mean that there aren't any other challenges or limitations. Keeping everybody's morale up is no small task, and costs are always going up. So, but if we can meet those costs in future budgets, then that's my role.